Thank you to Drs. McGarry and Sawicki for the opportunity to speak today, and also for organizing this very important session. These are my disclosures, most of which are unrelated to today's talk, although I do serve on the CF Foundation's Racial Justice Working Group. Many of you are aware that it was in 1938 that Dr. Dorothy Anderson described the clinical and pathological entity of cystic fibrosis. In her seminal paper, she noted that there was both a Black and a Puerto Rican patient. In fact, she said the racial and geographic distribution of CF was wide. But this message was lost along the way. And why did that happen? My esteemed colleagues who are going to follow me will talk to you specifically about racial disparities in cystic fibrosis, but I'm going to focus on how we arrived at bias in healthcare and what we can do to mitigate it so we can ensure the best possible care for everyone. To start this conversation, it's critical that everyone understand that race is a social construct. Race categories are socially and politically defined categories without biological basis. Dr. Szabo from the Max Planck Institute said that even between Africa and Europe, there is not a single absolute genetic difference, meaning no single variant where all Africans have one variant and all Europeans another one, even when recent migration is disregarded. And then Dr. Udell from Drexel said that if you make clinical predictions based on somebody's race, you're going to be wrong a good chunk of the time. For example, in cystic fibrosis, which is underdiagnosed in people of African ancestry because it is thought of as a white disease. We do have race and ethnicity categories in the US, but even on the government website, it says the racial categories included in the census questionnaire generally reflect a social definition of race recognized in this country because it varies by country because it's socially constructed, and are not an attempt to define race biologically, anthropologically, or genetically. The 5 categories of race in the US are white, Black or African American, American Indian or Alaska Native, Asian, and Native Hawaiian or other Pacific Islander. Now, race has been constructed based on physical characteristics, whereas ethnicity tends to be defined by shared cultural heritage, ancestry, language, or symbolic systems such as religion. In the United States, we have one ethnicity category, and that's Hispanic or Latino. The ethnic origins being in a Spanish-speaking country or Brazil, where of course they speak Portuguese. In spite of the fact that race doesn't have a biological basis, it does have consequences. Dr. Williams, in his discussion of racism in health, said, racism, an organized social system in which the dominant racial group, based on ideology of inferiority, categorizes and ranks people into social groups called races and uses its power to devalue, disempower, and differentially allocate valued societal resources such as healthcare and opportunities, and is evident in medicine. So how did we get here? Well, every system is perfectly designed to get the results that it gets. And I think we need to look at that design.
Oppression. It's a word that's often used as a blanket term, but there's actually a whole lot more to it. There are 4 interlocking aspects of oppression: ideological, institutional, interpersonal, and internalized. And it might seem like a small difference, but it's very important to be able to distinguish between each kind, because understanding oppression is the first step to fighting it. Let's start with the core at the heart of every form of oppression: ideology. Every system of oppression comes from the idea that one group is somehow better than another. Ideological oppression starts when the dominant group associates positive qualities with itself and negative qualities with the marginalized or othered group. Ideological oppression describes the deeply ingrained social root of inequality. It's the larger overarching idea that leads to the isms. For example, the idea that Black people are dangerous is ideological racism. The idea that poor people are lazy is ideological classism. Ideological oppression leads to institutional oppression. Institutional oppression is the way that systems and institutions manifest the dominant ideology. Institutions control access, Who is able to get to what and how? This includes legal rights, police practice, access to medical care and education, public policy, political power, and media representation. For example, when women make 2/3 of what men make, that's institutional sexism. When a building is constructed without wheelchair ramps, that's institutional ableism. All of this leads to interpersonal oppression. Interpersonal oppression is probably the easiest to recognize because it happens all around us. Interpersonal oppression is the way that people play out discrimination and violence on each other. It can take the form of microaggressions, jokes, stereotypes, and harassment. For example, when a student is bullied for being gay, it's interpersonal homophobia. When a Muslim person is told that they're a terrorist, it's interpersonal Islamophobia. And all those forces, ideological, institutional, and interpersonal, lead to internalized oppression. Internalized oppression is the way that people with marginalized identities internalize narratives of their own inferiority. It's what leads people to feel less than. This is the end goal of oppression. The oppressive party doesn't need to exert force any longer because the marginalized group is enacting oppression on itself to maintain the status quo. It's important to remember that it's never a marginalized person's fault that they feel internalized oppression. It's simply what happens when someone faces negative stereotypes, low expectations, and ongoing discrimination. So, for example, an immigrant feeling embarrassed about having an accent is internalized xenophobia. When a trans woman feels that they can never be a real woman, that's internalized transphobia. So, to review, the 4 I's of oppression are ideological, institutional, interpersonal, and internalized. Each of these types are interconnected and completely supported by the others. They can never exist on their own and can even be seen as a cycle. Now that you understand the different kinds of oppression, you're even more equipped to fight it. Don't forget that any effort to dismantle oppression should aim to address it at all 4 of these levels. Thanks for watching.
So this system has resulted in bias both from the patient side and from the provider side. So let's first focus on the patient side. There is clearly medical system distrust in Black, Indigenous, and people of color communities. And while people automatically go to Tuskegee, which is an egregious example of mistreatment, there are many, many examples that occurred before Tuskegee and are ongoing after Tuskegee. So for example, Dr. Sims was lauded as one of the godfathers of urogynecological surgery. He perfected a technique to repair fistulas between the bladder and the vagina. But how did he do so? He did so by practicing on Black enslaved women without their consent and without anesthesia. In the 1930s, eugenics was the rage. There was a system of eugenical sterilization and legislation for it. So they were trying to weed out the genetically undesirables of the population, and Black women of color were specifically targeted for such eugenics. And to the extent that there was even a phrase called the Alabama appendectomy that referred to involuntary sterilization. Of course, it wasn't just schools that were segregated, but also hospitals. So access to care was limited for Black people and other people of color. Of course, Tuskegee is an egregious example of research mistreatment when people thought they were enrolling in a trial to be treated for syphilis, but instead were just observed the natural history of disease. And this was funded by the US government and went on into the 1970s. Henrietta Lacks was a young Black woman who died of cervical cancer. Without her permission or knowledge, her cells were taken and they were used and expanded over and over again and used for thousands and thousands of experiments that made a lot of money. And neither her nor her family was aware or gave permission for the use of her cells. And you think those are historical examples, but it is ongoing. For example, Black women who are pregnant are 2 times more likely to die in labor than white women. And that's regardless of socioeconomic status. And the news has given us a recent example of a study in which poor Black children were over-enrolled in an observational study. Vitamin D levels were tested repeatedly and found to be severely deficient in these children and not treated because it was an observational study, but Black poor children were over-enrolled in this study. So of course, that has created transgenerational trauma, where word of mouth in these segregated communities is that hospitals are not going to help you, researchers are not going to help you, they're going to hurt you. And that impairs the physician-patient relationship. That's from the patient side. What about from the provider side? This image on the right is of medical students from Tulane standing in front of a former slave cabin that still exists in Louisiana. One of the medical students was quoted as saying, "We are our ancestors' wildest dreams," because there's historical context of exclusion in medicine. In 1847 was when the first Black student was able to graduate from a US medical school, but generally most medical schools would not admit Black students, thus leading to the formation of historically Black colleges and universities. In the mid-late 1800s, medical society membership was essential for referrals, hospital admitting privileges, licensure, and training. However, Black people and other people of color were excluded by their state societies and by the American Medical Association, leading to the formation of the National Medical Association in the 1870s. Because of this paucity of opportunities for training for the needs of the Black trainees and Black patients, between 1919 and 1944, there were between 118 and 124 Black hospitals in the US, trying to meet the needs of the providers and the patients. Of course, now, after the Brown versus the Board of Education, you can no longer exclude somebody from school by race. However, there's still underrepresentation and overtaxation of BIPOC medical school faculty. While the number of BIPOC medical students has actually increased in proportion, the proportion of BIPOC faculty in US medical centers has changed minimally over the last 20 years. And why is that? Well, it has a lot to do with the minority tax. So in other words, underrepresented minority and medicine faculty responsibility disparities. All faculty have to do research, training, and service, teaching and service in academic medical centers. However, there's an increased burden on BIPOC faculty, including clinical burdens, because underrepresented minority faculty are more likely to spend their time doing community work and caring for the underserved. They're also asked frequently to participate in diversity efforts without compensation. Many of us do this because we feel it's so important to make it better for the people behind us, but those efforts need to be compensated. Also, we experience racism both covertly and overtly, and we often feel isolated because we're the only person in our division or the department or in every meeting of the day. And those feelings of isolation compounded by racism lead to job dissatisfaction and attrition. There's often the inavailability of mentorship, and there are barriers to promotion that are inequitable. And these racial biases in medicine really do impact diagnosis and care. You'll hear more about the specifics of those in CF later, but there are some other egregious examples. So in this study done in 2016, so relatively recently, in 418 medical students and residents, Hoffman and colleagues studied beliefs regarding race-based biological differences. They asked questions such as, is Black skin thicker than whites, or are Black nerves endings or less sensitive than whites, meaning that they have more pain tolerance? And what they found was that those who endorsed false beliefs about race-based biological differences in pain sensitivity, that was associated with decreased likelihood of treating pain appropriately. So in other words, if you think that Black people don't feel pain in the same way, you're less likely to treat them appropriately for their pain. And medical schools continue to perpetuate bias through semantics, so using imprecise and non-biological labels that inaccurately conflate race and ancestry, using prevalence without context. So for example, saying that Black people have more rates of asthma than white people without actually talking about the effects on asthma prevalence of residential segregation and unequal access to high quality housing and healthcare. Race-based diagnostic bias. So for example, priming people to think about sickle cell in Black people without saying, by the way, this occurs more commonly in people who are at risk for malaria. Pathologizing race, so making everything seem like it's at a higher burden in people of color, even in cases where it's not, and teaching race-based guidelines. So how can we change this system and stop perpetuating the problem? Well, the first step is acknowledging racism. And in fact, both the CDC and the AMA have recently recognized racism as a public health threat. So at this point, we need to figure out how we break the cycle. How do we rebuild trust and take better care of people? So we need to think about addressing the 4 I's of oppression to rebuild trust and expand the BIPOC workforce. So one of the ways we can do this is by addressing implicit bias training. So because of the images with which we're inundated as children from the news, from the media, from newspapers, movies, all of us have biases. So we need to do thoughtful implicit bias training and become aware. So the implicit association test measures attitudes and beliefs that someone is unwilling or unable to report. And again, we all have them. But implicit beliefs are important because they can impact our interaction with our patients through nonverbal behaviors such as eye contact or lack thereof, speech errors, and avoidance behaviors that convey dislike or unease, eroding the physician-patient trust relationship. Training for implicit bias must not only include conceptual understanding and self-identification, but also proven behavior prevention. And there was a recent NIH seminar that talked about tips for improving the effectiveness of implicit bias training. And this training is necessary, but not sufficient. So we also need to read and understand history that includes BIPOC perspectives. We need to understand, ask our BIPOC patients and colleagues about their experiences and listen to them without invalidating them. It's also imperative as physicians, as providers, that when biological differences are noted between socially constructed categories of race and ethnicity, we need to ask more questions. So we need to assess variation in outcomes based on categories that better approximate ancestry. Also, we need to think about whether the differences we're seeing are attributable to migration patterns or environmental exposures. Think about the social determinants of health and the inequalities that exist there. We also need to increase workforce diversity. It makes a huge difference. So why? Because an institution that includes people from a given racial or ethnic community may seem more trustworthy and approachable to members of that community. Also, BIPOC patients may prefer and have better interactions and health outcomes with physicians from their backgrounds. Again, going back to that trust issue. And in fact, there was a recent study that showed in the United States, Black infants are much more likely to die than white infants. And there's a study that showed that Black infants taken care of by Black physicians had less mortality. So we need to think about this as we're recruiting our workforce. Also, BIPOC medical students express a greater commitment to serve the underserved and are much more likely to fulfill that commitment. We also need to address the components of the minority tax, so address diversity efforts in the workplace, address racism, isolation, mentorship barriers, and promotion barriers, as well as the added burden of doing diversity efforts without compensation. Finally, we need to address workplace culture, both for our patients and for our care providers. Workplace culture largely is determined by what is allowed or isn't allowed to occur. So if people are lax in responding to bigotry, then bigotry prevails. We need to speak up early and often in order to build a more inclusive environment for our patients and for our providers. So in summary, race is a social construct without biological basis. Historical and ongoing racism in the medical system explains current medical system distrust by many BIPOC, as well as the underrepresentation of BIPOC in the medical workforce. We need to have intentional behavior that addresses the ideological, institutional, interpersonal, and internalized or individual aspects of the problem, it is necessary for lasting change. So with that, I will say thank you to people with CF and their families who have been willing to provide their energy and voices to increasing awareness, as well as to the organizations like the CF Foundation for using their sphere of influence to affect change. Thank you.
Hello, my name is Susanna McCauley, and I'm going to talk about barriers to health equity towards closing the gaps. I'm coming to you from Chicago and wish we were all in person again this year. These are my disclosures. Most relevant to this presentation is that I am editor-in-chief for pediatric pulmonology, and I'm going to use it as an example of a couple of things later in the talk. I've also disclosed my funding sources here. More importantly, for this presentation, I need to disclose that I am a privilege exerciser. This is a term that I got from a book called Epidemic Illusions on the Coloniality of Global Public Health by Eugene Richardson. That describes that my opportunities and achievements are highly related to my race, and that's in quotations because this is a social construct, and the socioeconomic status of my own family. I also want to acknowledge many people because I'm constantly learning and unlearning, and need to acknowledge the scholars, community members, colleagues, and friends who have shared their knowledge and lived experience and shaped my experiences to grow a health equity lens. I want you all to lean into the discomfort of the work, as Brené Brown says, because it is uncomfortable to think about societal inequities, personal bias, and the outcomes of the people who we care about that have to do with structural and systemic racism. And I want to make sure that we're all on the same page in terms of terminology, and you've probably seen this cartoon or a similar one that points out the difference between equality and equity as being equality treats everyone the same. Equity gives people who have less more so that they can have the same outcome. Reality is that some individuals start with much less resource than others, and that really affects health in many ways. To get started, I want to talk a little bit about published findings and also flaws in describing differences and disparities, particularly across racial and ethnic groups. This was my first research project in cystic fibrosis, started when I was a resident and based on the fact that at the Johns Hopkins Cystic Fibrosis Center, we saw different phenotypes in our Black patients than in our white patients. And this study, as you see, was published. I also presented it when I was a senior resident at the Pediatric Academic Society meetings. And we really looked at racial differences. What we did was a matched cohort study. But we paused this because, as you know, in 1989, the gene defect in cystic fibrosis was discovered, as was the most common variant, F508del. And we paused to look at differences in the gene frequency, the gene mutation frequency. We found that Black people with CF had higher FEV1 in our center and fewer pulmonary exacerbations, but more hyponatremic dehydration and worse GI disease. If you look at this paper from our current lens, there are a number of flaws. Some are in reporting. We used race as a noun. We didn't capitalize it. Those are not what we would do currently. More importantly, we used race as a proxy for genetics. And although it has been validated in a number of studies, including one that Dr. McGarry is going to talk about in this session, that is an inappropriate use of race. Race-adjusted pulmonary function tests are extremely problematic. We know, and we've known for over a decade, that ancestry and ancestral genetic markers are much more closely correlated than race itself. And you can underestimate lung disease in people with CF and other lung diseases by using race-adjusted pulmonary function tests. And then finally, we had disregard of systemic racism that could have contributed significantly for some of the adverse findings in the Black patient population that we studied. Going to a much more contemporary paper, this is one that I had a role in, published in Pediatric Pulmonology a few years ago, and we looked at risk factors for mortality before age 18 years in the epidemiologic study of cystic fibrosis. And we looked at race and ethnicity as a minority versus majority, white and not Hispanic group. And that was somewhat based on the data at hand, but that really is somewhat flawed because we didn't have a database that had complete description of race and ethnic demographics. And we didn't really discuss that in the discussion section even a few years ago. And we didn't really discuss exposure to racism or structural racism as risk factors, even though we found that there was also, as previously described, an increased mortality risk in patients of lower socioeconomic status. We have come to improve our language in studies over time, and Dr. McGarry's work that I had the pleasure of collaborating with was published earlier this year. And we still had many of the limitations that I talked about a moment ago, but we had better discussion around the fact that genetic disease prevalence and mutations are heritable, but race is very imprecise. And categorizing people by race often promotes inequality, and that race shouldn't be used as an explanation for health disparities that emanate from social inequities and racism. I will also share that we initially had the word minoritized in this text and title. The reviewers did not like that. And we compromised because we wanted to get the data published. But the word minority itself is problematic, particularly since if you look at children in the United States, they are a rising majority, and minoritized much more recognizes the social and historical and current racism that affects health. I'm going to move now on to strategies that you can think about and incorporate in practice and with your team now. So one is to know and mediate your biases. There's been lots of discussion about implicit bias, which is related to primitive, automatic neurological processes that help us navigate in the world, and very well described in Daniel Kahneman's book, Thinking Fast and Slow. And everyone has implicit biases, and they're not a judgment of your character, but you need to understand them because physician implicit bias has been shown to negatively impact patient care and patient outcomes. And we know that that happens more so when clinicians are fatigued or stressed. And we are all fatigued or stressed some days, and maybe more often during a pandemic. You can be aware of your biases, and you can also consciously retrain your brain to think fast with less bias. And these strategies can be used to overcome flaws in your own decision-making or perceptions that can result in inequitable health care. It's important to promote equity in spoken and written communications, and I was alluding to this a little bit discussing a couple of articles earlier, but there are lots of guidances out here, including a recent one from the American Academy of Pediatrics on communicating about cultures that are not your own. We added a reporting of race and ethnicity guidance to pediatric pulmonology earlier this year. And very recently, the JAMA network, which has had its own issues with race and ethnicity discussions and reporting, but also published some excellent work on this, has updated its manual of style to give guidance on the use of race and ethnicity, including the important concept that these are social constructs and that there are sensitivities and ongoing controversies, that we have to be accurate and clear in language and terminology, and we should not report race and ethnicity in isolation. We have to look at methodology. If you use US Census Tract definitions, you don't have a full ability to classify the diversity of race and ethnicity present in the United States, for example. And also that this is evolving and we need to be sensitive as we continue to study this and try to communicate clearly. I would like to ask you to not use the term Caucasian in your writing about cystic fibrosis unless you are particularly studying people from the Caucasus. The geography of the Caucasus are seen here, and there are certainly people with CF in those regions. But this term was actually implemented in a very racist manner when it first started being used, and it's been widely adopted, but we can stop using it now so that we can be more precise in our communications. Practicing inclusive behaviors is very important, and this really has to do with getting to know people, whether they're people with CF, their families, or their colleagues as individuals, and not basing your perceptions of them on limited information, your first conversation, the way that they look or where they're from. Be very curious about their beliefs and experiences. Ask questions and practice narrative humility in listening to stories. It's also important not to assume a shared understanding of analogies or of terminology. And I give this example of dice. I learned this in an inclusive classroom teaching course where an anecdote was given about a student whose family had immigrated from another country shortly before the student started college. And when the professor used rolling of the dice as a way to show statistical probability, the student didn't understand that because dice are not used in games in the country that this person came from. So really think about that and how common language and simple explanations are more important. This is all very consistent with the PEP skill sets and content that have been rolled out by the Cystic Fibrosis Foundation about trust, dialogue, partnership, and goal setting, and to really get to know people sharing preferences, values, and needs. My next strategy is to understand the health effects of racism and other adverse experiences. So there are strong associations with experiences of racism and adverse health outcomes. And this is not only in many articles, but it is actually published in a couple of systematic reviews that are well done. Similarly, there are associations between vicarious or witnessed racism in children and the child's health outcomes. Adverse childhood experiences are also strongly correlated with poor social and health outcomes in adults and with poor health outcomes in children. And we know that Black and low socioeconomic status children experience more ACEs because of family circumstances and structural racism. And many have proposed that exposure to racism itself should be in the category of adverse childhood experiences, and some are studying it that way. I'm going to turn now to being trustworthy, and this is at both individual and institutional levels. Being trustworthy is important to have productive, equitable clinical interactions. At our own institution, our Chief Diversity, Equity, and Inclusion Officer, when she started, looked at data. This included our patient and family experience scores, which are overall quite good, but when stratifying them and looking at Spanish-speaking families, they were significantly below our other or mean outcomes for all groups, but also below benchmarks. She also found that structural racism is expressed by behavioral and security contracts disproportionately applied to families and patients of color. and designed a number of interventions from the individual to the policy level, with the institution squarely in the middle. And this is also related to my next strategy, which is to eliminate racist policies in your micro and macro systems. So look at your institutional policies. Does your organization have equal access to patients regardless of their payer, or does it stratify or prefer people who have private insurance? Do you provide high quality interpretation services in all settings? Do you have flexibility in late arrival policies for patients and families who may have long travel times or have unreliable or rely on public transportation? Do you have alternatives to the internet for accessing health information? And do you have telehealth without the internet for people who don't have reliable access? And this all stems from Ibram Kendi's statement that racial inequity is a problem of bad policy, not bad people. I believe that you have good people at your CF center, but you may have bad policy or have not looked at equity in some of your practices. It's also important to call people in and not out. As I talked before with the importance of leaning into discomfort, people have different knowledge and experiences of health equity issues. This is similar to this misunderstanding that I use because it's very contemporary and got a lot of social media and press attention. But I love this phrase from Oni and Uche Blackstock, who are both physicians, twin sisters, and health equity experts, and the importance of calling people in. Shame of calling people out only shuts down dialogue. It's not a productive way forward. And we can all work together if we call people in and even up to join discussions on overcoming inequities. The next strategy is to focus on structural competency. This is related to recognizing social determinants of health, but goes further in that rather passively knowing that social determinants of health can impact health outcomes, that they actually affect healthcare interactions. So an example is that there are structures that shape clinical interactions that may appear as something that you may call non-adherence or poor adherence. Issues in the community and lived experience of people that may make them miss appointments, that may cause food insecurity and therefore inadequate weight gain, or that might come to your attention as inadequate medication adherence. So thinking about all of those contributors and not just making an assumption about people based on something that happens that you see clinically. And there are a number of others, and I would like to refer you to this classic paper by Jonathan Metzl and Helena Hampson, published in 2014. Quality improvement is incredibly important in cystic fibrosis centers, and I want to give credit to the American Board of Pediatrics for recommending that we stratify process and outcome measures in quality improvement, because not all quality improvement efforts lead to equitable improvement. That's been found in various systems. And so you look at the breakdown among your patient population to see whether your QI efforts are helping everyone, and if not, think about ways that they can be more equitable. For those who are involved in cystic fibrosis research, it's incredibly important to design and conduct research with an equity lens. I don't mean disparities research or intervention research to overcome disparities, but all research, because inappropriate study design can actually perpetuate race science and detract from equitable care. I'm giving an example here of a course that I conceived of and recruited an early career faculty member who studies racism, Mia Hergaris, to co-develop and lead over the past summer. And this was for our Masters of Science in Clinical Investigation, but similar strategies can be implemented by people who aren't currently in a master's program. In conclusion, the CF community is actually very well positioned for equity action from the level of individuals all the way up to our healthcare systems and research community. And we need to do what we can with what we have, where we are. And we have organizational support from the Cystic Fibrosis Foundation and from the National Organization of African Americans with Cystic Fibrosis. So I thank you very much for your attention today, and I look forward to the discussion in the live session. Thank you.
Hi, my name is Dr. Megan McGarry, and I'm here to present to you Advances Without Equity for All. I have no relationships to disclose related to this presentation. So there have been great advancements in the cystic fibrosis community over the past few years. Most notable are the advent of CFTR modulators, but also pulmozyme, hypertonic saline, many various antibiotics, and enzymes. But these great advances in the CF community, do they benefit all? Do they benefit the entire CF community, or is it only for certain portions? So first, what we wanted to look at is the reporting of race and ethnicity of subjects of clinical trials of these drugs. So we looked at the clinical trials that were published from 1999 to 2015, and we found that only 18% of clinical trials actually reported the race and ethnicity of their subjects. Of the trials that reported their race and ethnicity, only 70% included any minority subjects at all. So about 27% reported 100% either Caucasian subjects or non-Hispanic white subjects. So this related into only 13.5% of clinical trials of these amazing drugs reported both race and ethnicity and included any minority subjects. However, when we look at the proportion breakdown of the subjects that reported race and ethnicity, what we see is most of these papers actually just had 100% white subjects. So they were overall 94% were white, 2% Hispanic, 1% Black, and only 0.1% Asian subjects. When we compare this to the overall CF population in the United States, we find that there is a big disparity. So this slide is looking at the patients who are Hispanic overall in the CF registry in the United States each year compared to Hispanic subjects reported in CF drug trials in the United States. So you can see that in green is the population overall, in yellow is the proportion in studies. Most years there were 0 Hispanic subjects in clinical trials. Only a few years were there Hispanic subjects, and never was there a year that it reached the proportion of the overall population in the United States. And when we break it down by drug class, you can see that only 4 drugs included any Hispanic subjects at all, and that was tobramycin, hypertonic saline, estrianam, and CFTR modulators. You can see only a small percentage of the clinical trials for each of these drug classes actually included Hispanic subjects. Next, we're looking at percentage of CF patients who are Black, and this is once again in the United States population by green versus the clinical trials in yellow. So you can see once again, most years there were 0 Black subjects included in CF drug trials, and never did it reach the proportion of the CF population. When we look at the drug classes that included Black subjects, only 3 drug classes had any Black subjects, and that was tobramycin, estrianam, and CFTR modulators. Next, we're going to look at percentage of CF patients who are Asian in the United States versus included in clinical trials. So you can see in green, the Asian population with CF in the United States, compared to in the yellow, which is across the bottom, only 2 years were there any Asian subjects with CF included in drug trials, and they were a very small proportion, nowhere near the overall population. And there was only one drug that was tobramycin that included any Asian subjects. So overall, patients who are race or ethnicity other than non-Hispanic white are vastly underincluded from CF drug trials. This is similar to what has been found, unfortunately, in other diseases, and really this represents for our overall population. We know then that these drugs have not been studied in minorities, and we don't understand whether these drugs actually work in these patients or whether there's different side effects overall. Now, we know that despite race and ethnicity being a social construct, that CFTR mutations vary by race and ethnicity in our populations. So across the bottom, you can see first non-Hispanic white, Black, African American, Hispanic, and other races. And then you can see the breakdown of CFTR classes 1 through 3 in yellow. In green is classes 1 through 4. Mutations that are known but unclassified are in purple. And then patients who do either have 0 or 1 mutation known is in red. So you can see that for non-Hispanic white, over 70% have class 1 to 3. A very small percentage have either unclassified or not fully genotyped mutations. Comparatively, you can see that for Black, Hispanic, and other races, it's a much lower percentage that have class 1 to 3 mutations and a much higher percentage that have either unclassified mutations or not fully genotyped. So this plays into a couple different problems that we're going to discuss. So the first is eligibility for CFTR modulators. As many of you know, is highly dependent on what mutation it is. So it's only FDA approved for very specific mutations. And so what we set to look at is whether there's racial and ethnic differences then in who actually qualified for CFTR modulators based on their mutations. So you can see across the bottom is any CFTR modulator, ivacaftor, lumacaftor, ivacaftor, tezacaftor, ivacaftor, or lexicaftor, ivacaftor, tezacaftor. In purple is non-Hispanic white, green is Black, African American, a light blue is Hispanic, and then a dark blue is other races. So you can see for overall, over 90% of non-Hispanic white patients qualify for CFTR modulators, while less than 70% of Black patients, about 75% of Hispanic patients, and 80% of other races. And then when you look at the specific modulators, there's not a huge difference for ivacaftor due to its mainly rare mutations. But when you look at the other 3 modulators, there's huge disparities. When we look at this a little bit closer, we know that eligibility by mutations for CFTR modulators is not the same across all ages. So for our infants and babies, the 0 to the half-year-olds and the 2-year-olds, there's not a difference in eligibility because it's just ivacaftor. But when you look at the 2 to 6, 6 to 12, and 12 years old, there's great differences based off of race and ethnicity between who's eligible. For example, if you look at the second set of information, which is the 2 to 6-year-old data, you can see that about a third of non-Hispanic white young children don't qualify for any modulators. But over 2/3 of Black children don't qualify for modulators. And then over half of Hispanic and other races don't qualify for any modulators. This is huge differences. When we look at the older children, teenagers, and adults, the greater than 12-year-old group, you can see that for the high efficacy modulators that are really disease changing. So it's 92% of non-Hispanic whites are eligible for those, but only 2/3 of Black patients, 75% of Hispanic, and then about 80% of other races qualify for these. And then when you look at the proportion that aren't qualified for any, not even the low efficacy. So it's 8% of non-Hispanic white, a third of Black patients don't have any qualifications for these, a quarter of Hispanics, and then 20% of other races. So these are just huge differences in access to these amazing medications. Now, genetic differences also play out not just on treatment, but diagnosis. So remember that, the mutation frequency is very different. And so this plays into newborn screens. Newborn screens vary state to state and are a combination of IRTs and genetic panels and or genetic sequencing. So we'll look at two different states and their differences. So the first is a paper that looked at detection of mutations by race and ethnicity in Illinois. And so what you can see is, if you look specifically comparing non-Hispanic Caucasian to Hispanic Caucasian, is that you can see that patients with either no mutations identified newborn screen or one mutation for non-Hispanic Caucasian was about 9.5%, but in Hispanic patients, it was 40% of patients either had 0 mutations or 1 mutation defined. Now, the paper that's down below is looking at the California newborn screen, and the California newborn screen is unique as it does IRT, a genetic panel, and then full sequencing. And the California newborn screen was designed to make sure that there is a over 90% detection rate for all minority groups. And so what you can see here is, if you look at the column on the right, is CF case detection rate. So 95% of cases are detected for non-Hispanic white patients, 91% of Hispanics, 100% of African American, and then 90% of other races or multi-race and ethnicities, and then 2/3 of unknown race and ethnicities. So with work, newborn screens can be equitable, but overall they are not, because of the way that they are so dependent on a genetic panel that targets just the most frequent mutations in non-Hispanic whites. And newborn screen is very important. So this is a paper that, this is research that has been presented at conferences and is in progress to be published. And so this is looking at babies that with CF diagnosed by newborn screen and looking at the age of their very first CF event. So the first time that they were made contact with the CF care team. And what you can see is that they're comparing white race, not Hispanic, to patients who are Black, Indigenous, or people of color. So, and you can see that the two curves are not aligned. So you see that patients who are white and not Hispanic are seen at a much earlier age than those who are other races and ethnicities. There's other data from the same study that found that this translated into there being a difference in weight for age and length for age between the ages of 1 to 2 years old, where patients who were white and not Hispanic had a higher weight and a higher length as well. So newborn screen is very important, and being diagnosed at a very young age is very important as well. So overall, why does this matter? Well, there's an increasing proportion of the CF population who is not white, and so this is going to be a bigger issue over time. And so this is where you can see the data is that this is registry data going from 2004 to 2019. You can see that African Americans went from making about 3.9% of the CF population to 4.7%. Other race went from 1.9 to 3.8%, and the Hispanic increased from 6.1 to 9.4%. But this does not tell the whole story, as when you look at the differences between those that are less than 21 years old and over 21 years old, you can see here, specifically on this graph on the right, that children with cystic fibrosis are much more diverse than adults with cystic fibrosis for a variety of reasons that we won't discuss here. But that in children with CF, it's about 15% of children are actually Hispanic, and about 8 to 9% of children with CF are Black. So this creates, it's actually a big problem in our pediatric CF community. So also why else does this matter? Well, minoritized patients have worse outcomes. So this is all data that was analyzed prior to the to CFTR modulators. So prior to CFTR modulators, there was increased mortality in minoritized people. So Hispanic patients have an 85% increased risk of death, and Black patients have a 48% increased risk of death compared to non-Hispanic white patients. Hispanic patients' mean age of death was 5.7 years earlier than non-Hispanic white patients. And in California, only 75% of Hispanic patients survived 18 years after diagnosis, compared to 90% survival in non-Hispanic white patients. Not only do they have increased mortality, but they have worse lung function. So Hispanic patients' FEV1% predicted is 5.7 percentage points lower than non-Hispanic white patients. In Black patients, FEV1% predicted is 3.9 percentage points lower than non-Hispanic white patients. And this ethnic disparity in lung function is not uniform across the United States. So the difference is much worse in the West. So we found that Hispanic patients' FEV1% predicted was 9 percentage points lower than non-Hispanic white patients in the West. Compared to the rest of the United States, it was between 4 to 4.4 percentage points difference. Besides lung function and mortality, it's known that there are increased pulmonary infections in Hispanic patients. So Hispanic patients have an increased risk of acquiring Pseudomonas aeruginosa and also converting to more severe forms such as mucoid, chronic Pseudomonas, multi-drug-resistant Pseudomonas than non-Hispanic white patients do. Not only are they at increased risk, but Hispanic patients acquire Pseudomonas and convert to more severe forms at an earlier age than non-Hispanic white patients. Hispanic patients are also more likely to have ABPA than non-Hispanic white patients do. And this disparity seems to widen as patients age. So it was much bigger disparity in the adults than the children. These are important because infections are such a large driver of lung function and mortality. So overall, the goal is to cure cystic fibrosis and to provide all people with CF the opportunity to lead long and fulfilling lives. And really now with the advent of all these huge improvements, that we really need to then focus on the people who are left behind, the population within the CF community that really are still continuing to suffer from their cystic fibrosis. And we need to focus on bringing equity to all these great advances that we have within our community. So we thank you for letting us present today.
Let me tell my story. I'm 58 years of age. 4 years ago, I was diagnosed with cystic fibrosis. So all this time, I've been living with that terrible disease that wreaked havoc on my body, with all different manifestations of typically CF brings to a body. The GI tract, which is the pancreas, the lungs, the hearing, all these many things that deals with cystic fibrosis, the wheezing, the asthma. I visited a doctor like 20 years ago. I walked in his office. He said, if it wasn't for me being African American, I would have cystic fibrosis. And since then, I was still going untreated, living with that disease, suffering, not knowing why I was going through all the many things that I was suffering. I would go out on these bike rides, on these long runs. I have these big grains of salt on my body. And I used to wonder, why all these grains of salt on my body? I knew I was different, but I didn't wonder. I mean, I wondered, and I just didn't know, but I knew I was different. Something was wrong with me. I knew that. I had a gut feeling. Something was different. Something was wrong with me. Because I suffered all my life. It goes way back. I can remember it vividly. Just being sick all the time. Stomach aches, missing many school days early on. Just being sick, staying home, curled up. If anyone ever felt that disease, especially in their GI tract, it feels like someone kicked you like a donkey in the mid of your stomach. And this is something you have to live with. Keep in mind, cystic fibrosis, you living with this. So I'm living all these many years. You know, I'm very emotional because I don't want anyone to go through this cystic fibrosis undiagnosed and not getting it. And along undiagnosed, and when you do get diagnosed, not having access to the proper treatment. I don't want anyone to go through this. I want them to have the proper treatment and to be able to deal with this cystic fibrosis. It is a terrible thing to have. Although this is a terrible disease, but there's so much hope, so much hope.
So what advice do you have for other cystic fibrosis patients in general and African American cystic fibrosis patients specifically?
My advice is to hang in there,
Okay.
stay encouraged, because they're steady coming up with different improvement and ways of making your quality of life much better. Cystic fibrosis patients. So just hang in there and try to stay encouraged.
Are you encouraged?
I'm very encouraged, especially when you have a supportive spouse like I have, Michelle Wright.
Don't you forget that.
Never forget that.
You know why?
That's why I'm here tonight.
The best is yet to come.
It has came. It has entered the room.
Night, night.
Who loves you, man?
Greg, you're muted.
Of course, I screwed up the very emotional moment there. Wow is all I'm going to say. And welcome to this symposium on health equity in cystic fibrosis care. I'm Greg Sawicki. I am a pediatric pulmonologist and the center director at Boston Children's Hospital. And I'm joined today by an incredibly important, well-versed, well-spoken, and really knee-deep in the weeds of this important topic panel. The talks that we've heard, I wish they were done in person. I wish we were all together in person to see this incredible group of individuals talking about their stories, and to see also the audience and to engage with you. But we'll do our best over the next hour over Zoom. Some questions have been coming in already, and please feel free to continue asking questions as we go through. Joining us on our panel are our speakers from the recorded sessions, including Dr. Jennifer Taylor-Cousar from the National Jewish Health, Dr. Susanna McCauley from Lurie Children's, Dr. Megan McGarry from the University of California in San Francisco, and Terry and Michelle Wright. We've also asked Dr. Terry Laguna from Lurie Children's and Mary Dwight from the CF Foundation to join us for this panel. I'm going to start off this discussion by, again, having Terry and Michelle reintroduce themselves, this time live, to this audience of over 500 attendees. And I'll leave the floor to you. And welcome, and thank you for sharing your story with us today and every day.
Thank you.
Thank you.
Thank you for that great introduction. Terry Wright, of course, Michelle Wright.
Yes.
59 years of age. I was diagnosed just 4 years ago with cystic fibrosis, and I'm living with cystic fibrosis. And I'm glad to be here today and to open up myself, as well as I have opened up my home to you all. So I'm willing to let it go.
And I feel the same way. We are celebrating our 21st wedding anniversary. And what's amazing about that, it's been so many times his health has been touch and go. And we didn't even know if we were going to make it to our first anniversary, not knowing what was wrong. So to have the opportunity to be here amongst all these phenomenal speakers and advocates and researchers, it's just phenomenal.
Thank you again. And I think what we're going to do is structure our discussion around, I think, a lot of the concepts and topics that were already brought up in the talks. And also think about it in the context of what the CF Foundation has done and is doing in their strategic plan with regards to cure, care, and community. And with that sort of kickoff, I'm going to turn it over to Mary to share with us a little bit about what the CF Foundation has been doing over the past year in this very important area.
Thanks, Greg. It's great to be here with all of you. It's pretty hard to follow Terry's story. What a remarkable story, Terry. I've heard you speak and share your story many times, and every time it's difficult to hear and it's powerful. So I want to thank you for that. And I really do appreciate the opportunity to share what the foundation is doing around issues of racial justice and diversity, equity, and inclusion. I think it's important to start by saying just how critical this is to our mission. We know that, as has been shared in all the talks, that significant health disparities are faced by people of color with CF. And we know that building an inclusive community is so critical to achieving our mission and fulfilling our promise. Our mission says that we will provide all people with CF the opportunity to lead long and fulfilling lives. We know and heard again today that people of color face significant health disparities, including delays in diagnosis, decreased access to relevant and culturally appropriate information on CF, quality and delivery of medical treatments, and inclusion in the CF community. For far too long, for decades, these disparities and experiences have gone overlooked. And while we've begun to take action, we acknowledge that we have significant work to do. I was going to talk a little bit about what we know, but our speakers have done such a beautiful job of outlining what the work is ahead. So I'd like to dive right into what the foundation is doing now. Last year, we established the foundation's racial justice efforts. And the goal of this was really to align the existing efforts that I'll speak about in a little bit that seek to address barriers, and also, very importantly, identify what else needs to be done, what additional and necessary work is left, and additionally provide focus and prioritization to this work. We've established both an internal working group at the foundation to develop and execute efforts to address racism and bias and embed racial equity in our own walls within the foundation. And we've established an external working group, many of whom of our panelists sit on that group, working to provide perspective and actionable steps that the foundation can take to address racism and bias in the CF community in areas of cure, care, research, and community. And I want to recognize not only all the members of that group, but particularly my co-chairs in this effort, JP Clancy and Sue Sullivan. And so I want to talk a little bit about this external work today, because I think that's really what our 500 plus folks can really make a difference with. Perhaps most importantly in this, we're actively working to engage people of color with CF and welcome them into discussions to inform and shape this work. We know listening, learning, and acknowledging is our first vital step. Very initially, this work has been anchored by a series of focus groups with people of color with CF to examine engagement barriers for this community. It's been ably led by Jessica Hudson and Christina Roman, and I want to thank them for all that they've done. It's been very brave work. And some of the key themes that we've heard from people of color with CF include a lack of trust within the broader CF community, including a lack of trust with the foundation, a lack of representation across care centers, the foundation, clinical trials, and others, and several of the speakers spoke about this. I want to share a quote from a focus group participant who said, quote, "It all kind of for me begins with not seeing a little brown boy anywhere I looked on the foundation page or social media. We know representation matters." We also heard themes about lack of education on diagnosis. Certainly Terry's story, unfortunately, bears that far too true. And also on treatments for people of color with CF. Again, a quote from our focus group feedback. "I had an experience this year in clinic. I was about to get a procedure and one of the doctors said, 'Oh, you have CF? Are you sure it's CF and not something like it?' Imagine how that feels." Again, Terry's story reflects significant and pervasive stories of delayed diagnosis and misdiagnosis, and a request for a need for targeted resources and CF support and visibility for people of color. So what do we do with this? What do we focus on? That work is still being built. The strategic plan to tackle this is continuing, and that work is ongoing. We hope and expect to have recommendations in the next several months, early into mid 2022. But I want to point out that in many places in our last long-term strategic plan, we're on year, I think, 3 of that now, that there are many themes that address some of these issues already, and we need to pull them out and elevate them and name them as for health equity and racial justice components. And again, our charge here is where can the foundation and the CF community have the biggest impact? First and foremost, health equity and outcomes. We need to understand the experiences of people of color with CF and raise awareness to the challenges they face. I think today's symposium has been an amazing start to that. We need to address misperceptions and build a community where all people with CF are welcome, represented, and valued. And we want to drive to improve health outcomes for people of color with CF as part of our mission. A few examples of some of the current work include newborn screening expansion with an emphasis specifically on addressing racial disparities and inequities. We're developing this strategy to improve newborn screening with a particular focus on delays experienced by populations of color. And potential improvements include transitioning all states to floating IRT thresholds and expanded genetic screening panels. We also have a genetic therapies working group to engage and educate those who are not eligible for modulators, as Dr. McGarry shared, many of whom are people of color. And as I hope many of you saw this morning, continue to press aggressively forward to spur the development of genetic-based therapies for CF, which can benefit all people with CF. I have to specifically talk about my area of expertise, our work in the policy and advocacy space on issues of inequities. Affordable coverage for high quality CF care remains paramount and a bedrock of the Foundation's policy agenda, as do efforts to address the high cost burden of CF and its significant unacceptable sacrifices that negatively impact health outcomes. And we know this is a pervasive problem for people of color with CF. We're also looking at workforce and expanding a diverse workforce, supporting the professional advancement of researchers and healthcare providers of color. We're evaluating our training and grant and support programs. And we're also engaging policy makers on these issues, such as responding to an NIH request about how to improve equity, diversity, and inclusion in the biomedical research workforce. And again, the bedrock of all this work is community inclusion and engagement. It continues to be essential to engage our communities of color and welcome this into this discussion. We've particularly focused on areas like our community conferences, including ResearchCon, with a focus on ensuring the content is accessible to a broader segment of the CF community, including those who have been diagnosed as adults or not previously engaged with the Foundation event. We understand how important it is to collaborate with the community, and we're building internal and external awareness of early and continued listening so that that feedback can be incorporated in our process. I want to hope and encourage everyone specifically an action that can drive this is to help us increase awareness of the Foundation's Community Voice program, where we're particularly focused on growing members of the community of color into that program, where they can help us drive some best practices. So I really look forward to the discussion. And again, thanks for the opportunity to share some of the things the Foundation is doing.
Thanks, Mary. And I think we're going to keep pushing on a bunch of these topics that you've brought up as well. And I'm going to turn back to some focus on community. And Terry and Michelle, there have been a couple of questions coming in from our virtual audience. One is, can you share maybe a few small things that since your diagnosis have made a positive impression on you during your interactions with your CF care team or with the CF Foundation? Anything in particular that's made you feel more included? I'll add to that, what has been maybe more negative, because I think it's great to highlight the positive, but I think it's important to push our clinical community to think about what remains being negative, even once the diagnosis was made. So I'll turn that to you.
Mm-hmm. Thank you. Once again, once the diagnosis been made for me, particularly, just my quality of life again changed, meaning that now that I'm taking these enzymes, now my food is digesting on my stomach, other than just sitting there fermenting and just making things worse. My breathing is much better now that I'm taking these nebulizer treatments, using the vest, all that, making a world of difference. Even though in my outdoors of gardening, now I know to wear a mask, not to get those foreign agents up my nose and in my lungs. So having that awareness now that I got this diagnosis, now things you need to protect your lungs, just your airways. And now that I'm taking time to doing that, that made a very positive impact in my life with my care team, for sure. And a lovely care team.
I want to give a shout out to his UAMS care team, from Dr. Larry Johnson to Dr. Jagani to Kathy. The whole team not only make him feel special and a part of the process, but me as well, because the spouse and the caregiver, they are an important part of this process. And what has been positive as well is being so well invited to the community. The Cystic Fibrosis Foundation has reached out to us and have collaborated with us. We know so many people there, and we're continuing to collaborate. All the members of this team we've collaborated with, from Dr. Jennifer Taylor-Cousar, who has been extremely instrumental in helping us with our CF screening tool that we're going to be launching, and Dr. Susanna McCauley from a newborn screening perspective, and Dr. Megan McGarry always being willing
to help, and Dr. Gregory Sawisky, who opened the doors for us to be here. But when you deal with equity issues, it goes beyond health. You know, we're here talking about health. We have other issues. And one of the things I would say that has been less positive would be the collaborations and partnerships. We would like to see more of that. We know we're making a difference. People reach out to us, let us know we're making a difference. They're happy to have us a part of the platform. But we would like to see more organizations reach out to us as an underrepresented organization and say, we want to partner with you. We want to bring you to our team and to be able to see more of those opportunities. But we're here to make a difference. We're here to stay. And we just appreciate all the love that we are receiving across the board.
Thanks, Michelle. And Dr. Laguna, I'll turn this to you because I think one of the things Michelle just brought up is around workforce. And it's something that Jen mentioned in her talk as well, but I know you've been doing a lot of work thinking about workforce development. And there have been some questions in the chat also about medical student training, fellow training, not just on the faculty level, but team member training, workforce training. How can you comment on how we as a community have done with this and what can we do better and what are the next steps?
Sure. Thanks, Greg. I appreciate the invitation to be here and to share the stage with such an amazing group of individuals. And, I'll first start by just saying how brave everybody on that gave a talk today has been. It's not easy to share your personal stories. It's not easy to spotlight racism, sexism, inequities, and bring a voice to them. It just isn't easy. And every person on this panel that did that, it just shows incredible bravery to be able to share themselves, to share their story, and to advocate for voices that just haven't been heard for a really long period of time. So thank you to everybody for sharing that. So I think people have talked a lot about the importance of representation, and CF patients, whether you're Black or Brown or any other race or ethnicity, I think we've known about a lot of inequities for a long time. Some of the research dates back into the 90s, and so we've known that a lot of these issues have existed, and we just haven't given it the attention I think that's been needed. And part of that is having people that are of different racial and ethnic, backgrounds being a part or having a seat at the table and really understanding what these patients are saying, what our population is saying. And that really points to, workforce diversity, as well as diversity in leadership positions. And, I think that the corporate world, I think it's understood this a little bit earlier than academic medicine has, which has been a diverse workforce leads to so many positive things, whether it's less turnover, understanding of racial and ethnic diversity, more productivity, more collaboration. There are so many positives of having a diverse workforce. And academic medicine has just struggled to really recruit and retain physicians and anybody else really from an underrepresented background. And that's just so important. Providers and physicians that are from an underrepresented minority are more likely to do research in that area. I think Dr. McGarry pointed that out earlier. A number of people did. They're more likely to go back and serve those communities, more likely to have a voice. And so it's really important for us to try to do what we can to not just recruit, but retain and create an environment of inclusivity for our physicians, medical students, fellows, everybody along the journey to becoming an attending physician. So I'll talk specifically about a couple of things that we're trying to do on a national level, because there is truly a commitment to improving the diversity, equity, and inclusion of our workforce from a pediatric pulmonology standpoint, and we're hoping that other specialties will kind of follow our lead. So I'm really involved in our American Thoracic Society, which is our society that basically, kind of has an umbrella for all pediatric pulmonologists. And we are really working with all the physicians that take care of CF patients nationwide to how do we do this better? How can we recruit more of a diverse medical workforce? What are the trainings we need to do? How do we do this better? And so there are many active initiatives on behalf of the American Thoracic Society and your pediatric lung doctors out there to try to make our workforce a lot more diverse. So there's clearly a commitment. There are resources that are being allocated to that, and there are people who have a voice in a national platform that are trying to move this work forward. So I think that there's a real effort nationwide on this initiative. I think people from underrepresented minorities that are in academic medicine, and there are less than 10% of all of us nationwide are from an underrepresented minority. So there aren't that many, but we're trying to have a powerful voice, trying to advocate for each other, trying to advocate for medical students, residents, fellows, to try to help support and build these careers. And I look forward to partnering with the CF Foundation on how we can do this better, how we can encourage trainees from diverse backgrounds, how we can support their clinical training, their research careers, their path of professional development, because that is so important. How do we build that workforce? And specifically for our CF population, it's going to take work. It's going to take effort and resources to really create that diverse workforce that our CF patient population needs. So I look forward to that partnership with the CF Foundation moving forward.
Suzanne, I wonder if you have anything to add from your positions of leadership in pediatric hospitals, both from a research and a clinical end.
So one of the things we all have to think about is the pipeline. We have marked underrepresentation of racial and ethnic minorities in science and medicine. The National Institutes of Health is really beginning some programs to try to help that. This has been an effort for many years, but there are many barriers to people who have been minoritized entering medical school. So some of the things that we're looking at are programs for college students, for high school students, and really looking at, why is it that there's such overrepresentation of white, wealthy people in medical school classes, even now, when efforts have been going on since the 1970s to improve this. So we have to reach back as well as attract and retain people who are thinking about entering cystic fibrosis, pulmonology related fields when they are in medical school.
Jen, I want to turn a little bit, there's been a bunch of questions around clinical research, and I know that in the talks it was talked about around access to trials, but also the sort of concept of participation in research and how that's been challenging for communities of color historically and even in the present day. One of the things you mentioned in your talk was a more recent example of the vitamin D study in asthma. And I think for those of us who participate in clinical research, it's important to recognize that Tuskegee is an important historical moment and that we need to understand, but these moments continue to occur today. And so I'm hoping you can maybe expand a little bit about your thoughts around how do we build trust in communities to participate in research, given what we've seen both historically and in the present day.
Yeah, I do think it's really important for people to realize that it goes beyond Tuskegee. And that was the reason I wanted to bring up some of the things that are ongoing. So it's not just a distrust because of Tuskegee and other research, it's also because of the way people are currently treated in the medical system, like Terry experienced and others have experienced. So addressing racism at every level is part of that. So I think with the vitamin D study, those were two really respected colleagues who were leading that study. But that makes it even more important for me to point it out, because I think we have to realize that when we are approaching people who haven't been in studies and maybe don't have the health literacy that we have to be even more conscientious about how we're consenting them in studies. There was another example that I didn't put in there about immunizations that were given to people that weren't FDA approved. And they actually didn't tell people that they weren't getting an FDA approved immunization. So those things happen over and over again. And sometimes I think, you know, the Sims example is one who was clearly racist and not thinking about the people he was harming. But these other people who are doing these studies are actually really good people, and they still are making mistakes. So it just reminds everyone that you have to be intentional about reviewing your consent forms, reviewing the way you're talking to people about the study that you want them to be in. And I think one of the things that I mentioned yesterday during a discussion was with genetic therapies, for example. Right now, we haven't approached many people of color. We haven't diagnosed them, and we haven't approached them to participate in any studies at all. And then all of a sudden, they're in the remaining population who don't have a modulator, and they're overrepresented there. And so it's like saying, hey, I know we haven't ever talked to you or even acknowledged your existence, but now we want you to participate in this gene therapy study, and we promise it's safe. Never mind all of the historical and ongoing mistreatment. So thinking about that as you approach people and talking to them, you know, don't go in there the very first time you meet somebody and say, hey, I want you to participate in the study. Get to know them first, their background. And if they're saying no, ask them why they're saying no and really understand that and don't dismiss it. I don't know if Terry wants to, sorry, I was going to say Terry may want to comment more, because I don't know if he's been approached in particular about being in studies and how that's gone for him.
Right. I have been approached on being in a couple of different studies, and I've been open-minded to it. I was real pleased to know about, I was in that 10% of that Tricapta, but now I'm eligible for it and I'm presently taking it. And so it definitely has changed my life. My sinuses, everything just opened up. It's really been working great for me. But, you know, as Dr. Taylor-Cousar said, I do have some maybe reserve just right away, just want to be in a trial clinic, you know, because you go in just really not knowing, you go in your bias, you've heard about things. So just open up and just build a relationship with someone first, other than just let me just start studying you, put you on something and see how it works. Because, you know, we all watch television, right? See the rats, so to speak.
Let me elaborate a little bit too. Interesting enough, I was born in the hospital, John A. Andrews Hospital, that the Tuskegee syphilis experiment took place. And so I know that's one of the things Tuskegee is infamous for. We also, a lot of positive things from Tuskegee University to the Tuskegee Airmen, but there are some mistrust issues. And one thing I do want to stress, I commend a lot of the efforts that's being done from the Cystic Fibrosis Foundation, bringing Dr. Jennifer Taylor-Cousar on as an advisor, and some of the other efforts, even from the ATS featuring Terry on Patient Voices 9. But one of the things you all have to remember, internally, you can only get so far. So you have individuals like Terry and myself that have experienced this, that understand health equity from a unique perspective. Partner with us, bring us to the table as consultants, because what you're missing, we can really help address those issues. If you don't bring that external component, like a Terry and Michelle from a health equity perspective, to the table, and you're trying to check and balance each other, then you go continue to see similar results, but not understand, like Dr. Macaulay mentioned, we're putting these systems in place. Why aren't they working? I experienced that even with my tenure as a regional CEO with the American Red Cross. I was told Black people won't give blood. I would say, why won't we give blood? Let's investigate that. Let's bring the community in to understand the why, and let's make a difference. And that's why it's important for the organizations that truly want to make change then you have individuals like us that can be an integral part of that process, and we're here to make a difference.
So powerful, Michelle. I mean, so powerful. I think that's what we need to hear day in, day out, and begin every health equity talk, every health equity meeting with that. And I just want to re-say what you just said is, let's bring the community in. And I think that's where it has to begin. That's where it has to end, is that we need to begin and end with the patients, the people who this is affecting, to really understand, to really make the change. So just thank you so much for saying those powerful words and then being here today.
And Megan, in our audience have been multiple comments about just sort of implementing all this at every process. Whether we're doing a QI initiative or a research study design or a planning meeting around a protocol, we should at every juncture say, how are we addressing equity in this particular initiative? And it may be different for different ones. The issues around newborn screening are going to be somewhat different than a clinical trial for a therapy that may have different inclusion and exclusion criteria. What we do at a center regionally may matter, or different, based on populations. And I'd love to hear a little bit, Megan, about the California newborn screen program, because it's so unique in many ways, and how it addresses this. But I think it's about taking a step as a team at every juncture and making sure that it's a explicit point. And I think you're right, Michelle, bringing in the community. And I think all of us at care centers can identify people within our local hospital community networks that should be at the table. We have a long tradition in the CF centers of developing parent and family advisory groups and family nights and all these things. And I think we just need to expand and continue in that vein. The messaging, and I see it in the chat around CF being a white disease is such an outdated thing. And I think, again, thanks, Jen, for bringing up that original paper from Dorothy Anderson, which points it out, from the day of description. Susanna,
I can just add one repeat plug to also really encourage your patients to sign up for the Foundation's Community Voice, which enables them to help be at the table and design a whole host of things, from our materials to clinical trial guidelines. So it's another option for those national level programs, Community Voice.
So Susanna and Terry Laguna both have comments.
Yeah, I just wanted to reflect back on something that Terry and Michelle had said about how much they love their center, and to go into the research on engaging participation in particularly clinical trials, which is that it's very, very important that a person people who have been minoritized have a relationship with, discuss it and recommend it to them. And so very, very often in a CF center, that may be the physician who cares for that patient primarily. It's really important to have discussions that are not just at the time a study is enrolling, but ongoing. There is this new therapy that was approved in 12 and older. Your child's not eligible for it, but there will be trials coming. Very brief. And hearing what people have said in the Racial Justice Working Group that the CF Foundation is running, many people are not hearing that. And then I also just want to say it's also important that the entire healthcare system present itself as trustworthy, that the policies are, because every bad experience someone has before they see you or are contacted by your research team is going to make them less enthusiastic, more worried about the potential of participation.
The quick comment that I'll make really just builds off of what Terry and Michelle have said and what others have said today. Asking asking people of color, people from underrepresented groups to share their story, to have focus groups, to talk to them is hard because they're sharing painful things and ways that they may have been treated wrongly or diagnosed late or had an impact on their lives. And those stories are difficult to share. But yet they do. Terry and Michelle come on here and tell an amazing story of his journey. And I would say now the onus falls on us as a community. We have to do something about that. So asking people to continue to share how they may have been wronged by the medical community or mistreated by other people, I mean, yes, I think we have heard that there are issues, and now it's on us to actually do something about it. So I just don't want us to forget that action piece is what these communities are looking for from us. It's great that we talk about this, that we identify issues. Now we have to do something about that. And so otherwise, we're not going to generate that trust that the communities need to have in us, that we're actually going to be able to make a difference. So it's key that we actually take this information and make it happen and implement action.
And I would like to add one more thing. You know, our voice as co-founders of the National Organization of African Americans with Cystic Fibrosis is so important. People rely on our voice and they see us as that advocate. And we so often can help bridge that gap and that disconnect. So we ask organizations, you know, reach out to us, collaborate and partner with us, because we're able to get done with underrepresented groups that other organizations cannot, because we have built that credibility and that trust, and because of Terry's story. So, you know, everybody can make a difference and get involved, and everybody can have some type of involvement, even with our organization. That's why, again, we're so grateful for everybody that's been a part of this panel, supporting us, the community supporting us, our board members supporting us, but continue, because we are that rare voice for the not only just the African American community, but the BIPOC community.
And I just want to say one last thing. And what we're doing in the whole CF community and all that's involved, we said that we love it. And love is an action word. If we just can put our stuff in action, and then we can sit down for a second.
Yeah.
Yeah, and along the lines of trustworthiness, I want to go back to one of the points that I was making earlier in my talk, and that's about bias and knowing your own biases, because there's lots and lots of data that says that if you're really uncomfortable with a topic, that you're going to interact with the person differently because of that, probably the biases that you don't even realize that are there. So you can do little things like avoiding eye contact or rushing out of the room or not explaining things in the same level of detail that you'd explain it to somebody with whom you felt more comfortable. So understanding your own biases and working to address those, like the quote from Ibram Kendi about being an anti-racist, is a constant ongoing process, and admitting when you make mistakes. And, you know, saying, hey, I'm sorry, I said that wrong. I didn't mean for it to be that way. And going on from there, because trying to cover it up, again, erodes that trust rather than building it.
Megan, you commented a lot in your talk about existing and known disparities in outcomes, access to therapies, access to trials. I'm wondering if you could, and this is a question for you and then anyone else, if you could identify what would be one measure of success in terms of an actual action over the next year to 2 years that you think would help to sort of close these gaps.
Thanks. So I think one of the first things is that we can only act on a disparity that we know about. So that we need to know where these disparities lay. And so one of the first things really that like struck me from the research in cystic fibrosis, and this is true elsewhere, is that often like race and ethnicity of subjects is not even described in papers. So if you look at the majority of clinical trials, there's no information about it. Shockingly, when there was a paper about 2 years ago that was published, a large clinical trial, when I wrote to the authors within hours of being published, they told me there wasn't enough room in the paper to describe race and ethnicity, not in the supplement, not in the paper. So I think that's like one thing that people can do from the research community right away is even just like describing race and ethnicity of subjects. That's like bare minimum. Second is actually looking at who they're recruiting. So there was a question that came up about diversity of centers. So one of the first thing can just be is like, where are we actually conducting these trials? If we're conducting them only in, for example, Wisconsin, where it is like a higher percentage of non-Hispanic white patients, and when we're not conducting these studies in centers that are very diverse, that might be smaller or not have done as many studies, then that's going to lead to differences in the diversity of our subjects. Other easy action items, well, not easy, but more obvious action items was the diversity of your CF center staff. So what is the diversity of your research coordinators? Do you have somebody that speaks Spanish? Do you have somebody that represents the subjects that you're trying to recruit? Do you have anybody that can speak to an experience that is different from a non-Hispanic white person? That will be a starting point when you're looking at your own center. So one thing that we've done here at UCSF is that every year we have a parents' night where we talk about all the research that's going on overall. We talk about the research that's coming up so parents can be aware of trials and research going on that their own child may not be able to participate in. And what we started right before COVID is that we did one exclusively in Spanish. So we had interpreters that were interpreting Spanish to English for people like me who are not fluent in Spanish. And we invited the patients from all over the Bay Area. And I think that's really important of saying, like, you're not just like a small group that we're going to accommodate. We're actually going to make an event for you, that you belong, that that you are seen, that you are important to our community. So I think there are a lot of areas where we can do better. I think there's things that we can do as a community overall. There's things that we can do as a center, and then also then as a person. But I think it always comes back to listening to the patient. And I just want to talk about sort of two different patient experiences that I heard recently that are really powerful. So one is through some of our CF Foundation listening groups. We heard from a mom who is Black who had a child with CF. She had a baby who had symptoms of CF, and she had tremendous struggles to get a sweat test for her baby. That is appalling. And once again comes down to the bias of not recognizing that CF occurs in patients of all races and ethnicities. We heard from a case report yesterday at the Pediatric Fellows Conference of a baby who is Bangladesh, whose mom knew she was a carrier, and the mutation was known not to be showing up on the newborn screen, and yet somehow still got missed until the baby was failure to thrive and sort of presenting in a severe way. Like, that's not okay. And when we're thinking about barriers to studies, two things, I just want to share that, we have had patients who have a lot of immigration issues. So we have patients who on the way to visits, baby with CF has a blowout diaper, you have to pull out on the side of the road, they get stopped by immigration. So there are a lot of things that you may not think about as a reason that patients may be hesitant until you really sit and listen, until you really think about where they're coming from on like the great barriers they are up against to come to visits, let alone to come to research visits. So, I think there's just a lot of listening and self-reflection that we need to put in, and then immediately move to actions, because we cannot hear these stories without and then not respond. So I'll leave it at that.
Thanks, Megan. And I think, we're coming close to the hour, but I think I want to keep this conversation moving here. And if we think about maybe gathering in a year from now, right, and reconvening and having another discussion, I'd love for everyone to sort of chime in on sort of one piece of advice that you have for the community right now, and maybe one thing that you would like to see done in the next year, so that we can come back next year and check our work, so to speak.
I would start that off. Now I would say there is hope, but a year from now, I would like to say there is change.
I would like to say, yeah, we hear you. Yeah, we see you. We're looking. That's it.
I'll go next. I would like everyone to think about the 4 eyes of oppression, because every single one of us has a sphere of influence. So whether you're going to influence people on your care team or your entire center or your institution or at a big conference like this, think about where you personally can make change, especially if it's systemic change. And so what I'd like to see next year is that all of our moderators and every single session, diversity has been considered: gender diversity, racial diversity, senior versus junior people. Like every single time we think about moderators for sessions, whether it's CFF or ATS or where we are, that needs to represent the community as a whole and not just a certain segment of the community.
I'll follow up on that, directly related. Everything we do, we have to think about equity. Every clinical policy, every guideline implementation, every QI project, every research project needs to be designed with an equity lens. And you need to be able to measure how your equity efforts are working. Because otherwise we have this, and what I would love to see in a year is that there are still focus sessions on equity and diversity and inclusion, but that this is embedded in all of the science, including preclinical science, as we go forward.
If I can build on that, I love that, Susanna. And I think as we reflected on where we are at the foundation, as I mentioned in my remarks, there are many places where you can see equity as a subtext of things that we've named as priorities. And where I'd like to see it is to elevate it up and name it and say, this is a part of this goal, or this is the goal, because it's so pervasive. So let's call it what it is and be clear about our goals and focus. And I think we can get there.
I can go next. I think one piece of advice I would give, and speaking now to underrepresented minorities in healthcare and also people with CF from an underrepresented minority community, I would say don't doubt your voice. I think sometimes you can be made to feel that what you say doesn't matter or doesn't have an impact, or other people around you are acting in specific ways and you start to doubt yourself, like maybe this is me. But keep talking. Don't doubt yourself. Keep telling your story. I think that's very, very important. In a year from now, what I'd like to see is the CFF identifying research priorities, research grant funding, training grants that are specifically trying to help build diversity in our workforce.
So I'll go off of Terry. So I think to listen and to elevate the voices and stories of your patients. Do you know their story? Do you know the struggles that they dealt with to get to your clinic? Do you know the struggles and the barriers that they're listening to every day? And then you need to elevate those stories so that there can be action onto them. And I think that's really where the caring for your patients comes in. And then for the action item, so sort of the similar to what Terry just said, but I'm going to say it a different way, is put your money where your mouth is. So there needs to be action and priority for this. So there needs to be, as the NIH does, there is diversity requirements in order to get funded, in order for trials to go out. And that's really where an action item can be from, where we want to see where the CF Foundation is from there. Also, I would really like to see that this would move beyond the CF Foundation for advocacy, because patients don't come into the CF world. They come from family medicine, internal medicine, ER, the pediatrics office. And that's where we need these patients to get picked up, since they are getting missed through newborn screening and other sort of traditional ways that we bring them in.
And I'll just add that, as we celebrate the successes of the CF community, and we're celebrating them throughout this meeting, we've already started to hear really incredible population level data on health outcomes with respect to Trikafta and other therapies. As we're also dealing with a society that is grappling with inequities from the COVID pandemic, structural racism, all of the political turmoil that we're facing, I think we are really at a crossroads to move, I think, exactly as Terry and Michelle said, from listening to acting. And I think, as someone who comes from, as Susanna, I think it was great that you pointed out, many of us in CF care centers are coming from a place of privilege, from either our own ethnicities or our socioeconomic status or our educational status. I think we have to own that and also become allies to all of our community. And I think that comes from, as you said, Michelle, so wonderfully many times, engaging, listening, but also having you be an active voice at the table. And I hope that we can have and continue these kinds of conversations and not just talk about it, but show that we've done it. There's a lot of things that we haven't done here and talked about. I think we could have had this panel for 3 hours. We didn't really talk a lot about Latino, Hispanic populations. We didn't talk about LGBTQ populations, although I'll put a plug for this afternoon's symposium on gender diversity in cystic fibrosis that Dr. Laguna will be a part of, and that we've done some work in. This is not about individual silos. This is about all being part of the same community. And I think we have a few minutes left. If there's anybody else who would like to say anything, but I do want to give Michelle and Terry the last word, because you have been incredibly important voices, not just today, but for the last several years. And I know that you will continue to be so.
We just want to thank you again. I want to say again, happy anniversary to my husband. Happy anniversary. I am so proud of him, because it's not easy when I see him getting emotional. And I won't get emotional, but I'm so proud of him. I want to say individually we have energy, but collectively we have synergy. We're so stronger together. And there's a place at the table for us. And just like you may need us for these issues, we need your support. Our organization needs your support. Our organization is the voice for African Americans with cystic fibrosis, and now BIPOC communities with cystic fibrosis. So when you're thinking about supporting organizations in the smallest of ways, whether it's an encouraging word, whether it's a collaboration, a partnership, think of us, because without you, the community, then we are disadvantaged yet again in doing what we are trying to do to make a difference. So we need you.
That's right. And one thing that all these different communities have in common, we have CF. So we all one.
We're all in it together.
Let's get together.
And we want to thank you too, again, and the Cystic Fibrosis Foundation for being forward thinking and even talking about this topic. And I want to really commend you, Dr. Sawitzky and Dr. McGarry, for leading this, and to be at the table again with Dr. Jennifer Taylor-Cousar and Dr. McCauley. We know we're moving in the right direction. Thank you all.
We win.
Together, we win.